Hereby I open this academic ceremony at Maastricht University. First of all, I welcome Mr. Mohammed Nazir Ayub Kahn, and he will defend his thesis in public, and the thesis is entitled Overcoming Barriers in the Prevention of Surgical Site Infections, a Master Plan Employing Task-Based Interprofessional Training. Welcome to all members of the degree committee, and in particular the three supervisors. And the supervisors are Professor Walter van Mook. He is Professor of Postgraduate Medical Specialty Programs at Maastricht University and affiliated with Maastricht University Medical Center Plus. Professor Diana Dolmans, she is Professor of Innovative Learning Environments at Maastricht University. And Dr. Danielle Verstegen, she is Associate Professor and Director of She Educates at Maastricht University. I will introduce the 6 opponents later during the ceremony, and I welcome you here in the aula, and of course I welcome all the followers of the live stream. Mr. Kahn, may I invite you to give a summary of your thesis? The floor is yours.
Thank you very much. Dear Rector, highly esteemed opponent committee members, my supervisors, colleagues, and friends, good morning. Today I am going to share our insights into the barriers which hinders the implementation of surgical site infection guidelines in the operating rooms of a low-middle income country, and our insight into task-based training which we use to overcome these barriers. So first of all, what is surgical site infection? Surgical site infection is an infection related to an operative procedure. It is an infection near the surgical incision within 30 days or within 1 year in case of implant surgery. Why I am highlighting this problem too much? Because it has an impact on the patient's life and a big burden on the healthcare system. 1 in 10 people in low-middle income country gets surgical site infection after surgery. This risk is 3 to 5 times higher than high-income countries. And the condition is much more worse in Africa, where 1 in 5 women gets surgical site infection after delivery with C-section. This does not mean that high-income countries are free from surgical site infection. The incidence of surgical site infection in high-income country is 1.2 to 5.2%. It means 500,000 people every year get affected by surgical site infection in Europe, and the healthcare system have to spend 19 billion euros for the treatment of these patients. The incidence of surgical site infection in United States of America is 1 to 2%. These patients, after having surgical site infection, spends almost 400,000 extra days in the hospital, and for that, the healthcare system spends $10 billion. But it's very interesting that 50 to 60% of these infections can be reduced. How? By simply using the core components for effective prevention of infection. The core component 1 lays down the foundation for all other components. And the core component 3, infection prevention and control education and trainings, builds the capacity of healthcare professionals to lay down the guidelines which prevent surgical site infection. In our project, we did 4 studies. In our first study, we want to have an insight into the barriers which hinders the implementation of surgical site infection guidelines. In our second study, we early involved the healthcare professionals during the design of our training. Then in our third study, we implemented it on a larger scale after remodifying, after having a feedback from the healthcare professionals. In our fourth study, we designed an outline of a master training plan, and we involved different stakeholders in it. So our first research question was, what factors hinders the implementation of surgical site infection prevention guidelines in low-middle income countries from the perspective of healthcare workers? We did a mixed method study with healthcare professionals working in the operating rooms of 2 university hospitals in the capital city of Pakistan. Both of these university hospitals are attached with the medical colleges, dental colleges, schools of nursing, and they are recognized for postgraduate training by College of Physicians and Surgeons, Pakistan. We collected our data through questionnaire and interview. On the basis of that data, we can divide the factors which hinders the implementation of surgical site infection guidelines in the operating rooms of low middle income countries into two groups, the factors at individual level and the factors at the institutional level. The factors at the individual level consist of lack of awareness of the guidelines, no education and training available to healthcare professionals, there is no policies and procedures to protect the right of the patients. Similarly, the barriers at the level of the institution consist of no facilities are available to healthcare professionals to have education and training. They are not expected to follow the guidelines. There is lack of culture to follow evidence-based guidelines in these institutions. And moreover, there is lack of resources and there is lack of surveillance system in both of these hospitals. So on the basis of this study, we can conclude it that there is lack of education and training programs available to healthcare professionals in low middle income countries, as a result of which there is no culture of evidence-based clinical practice to prevent surgical site infection in these countries. There is lack of surveillance system also. So after having insight into the barriers which hinders the implementation of surgical site infection guidelines, we went through a literature. We found that no training is available to healthcare professionals based on current instruction design principles. So we designed our training based on using authentic tasks in the form of a video showing the best practice, role plays, case scenarios. These tasks were of various types so that healthcare professionals, when they go back into their context, they can deal with different situations. These tasks were simple to complex, although the tasks were simple, but they were from the real practice of healthcare professionals. Guidance was available to healthcare professionals in the form of a reading material and feedback in the form of scaffolding when they were solving these tasks in small interprofessional groups. So, after designing this training, we want to involve the healthcare professional early in the design. So we want to know what are participants and facilitators' perceptions and experience of an interprofessional task-based program to prevent surgical site infection in a low middle income country. We did a design-based research with the healthcare professionals from the real context of operating rooms. We collected our data through questionnaires and focus group interviews. And we found that when different healthcare professionals learn from each other by using professional tasks, their learning get enhanced. And similarly, especially when the facilitators provide scaffolding to them. So on the basis of this, we can conclude that the healthcare professionals have the positive views about the task. They were happy from the opportunities provided by them to interact with each other during solving the task. And it seems that this training is going to bridge the gap between knowledge and practice to prevent surgical site infection in the operating rooms of low middle income country. After having a feedback from healthcare professionals, facilitators, we redesigned our training according to the feedback, and now we want to implement it on a larger scale in the operating rooms. So we want to know how do participants perceive and value a revised training program to prevent surgical site infection. What is the impact on knowledge gain and perceived behavioral change? We did a mixed method studies with the healthcare professionals in the real context of the operating rooms. We collected our data through MCQ test at the start of the training, and then at the end of the training with post-intervention MCQ test. Participants' satisfaction was evaluated by a questionnaire, and 8 weeks after post-training, the self-perceived change in behavior was evaluated by a questionnaire and interview with the participants. We found that participants were satisfied with the training. There was significant gain in knowledge with pre-test and post-test knowledge scores, and the participants self-perceived change in behavior after the training. The participants perceived that this training produced well among them to overcome the barriers to prevent infection, and they said that interprofessional approach improved understanding of one's roles and responsibility when they solved the task in small interprofessional groups. After having this training, the healthcare professionals went back to their real context, and they tried to apply the knowledge which they learned during this workshop or during these trainings, and they found that there are certain barriers also which hinders the implementation what they learned. They said that rapid turnover of healthcare professionals in these university hospitals complicate the implementation of guidelines. Moreover, there is shortage of supplies of different things, which also hinders the implementation of surgical site infection in the operating rooms. And conventional practice of some of the senior colleagues also hinders the implementation of these guidelines. So we can say that training was well perceived by the participant. There is significant gain in knowledge, and the task-based training promotes transfer of knowledge to workplace. After having, again, a feedback from the healthcare professionals, we found that there is rapid turnover of healthcare professionals. So we again brainstormed, and we thought it's better to design an outline of a master training program so that we have training, retraining, training, and retraining, so that whenever the healthcare professionals are coming, so they have a training. So we designed an outline of master training program. Now we want to know how do policy makers, teachers, managers perceive the outline of a master training design to enhance awareness about surgical site infection prevention and behavioral change in a low-middle income country. We did a qualitative individual interview study with policymakers, teachers, and managers. We collected data through semi-structured interviews, and the stakeholders perceived that discussion of authentic tasks fosters the transfer of knowledge to the workplace, and the master training plan will help to change and sustain behavior. And they also find that this training is a cost-effective, especially in those countries which has limited resources. But they also raised a red flag that interprofessional reflective learning may come with challenges. So on the basis of this training, we can conclude that training going to foster transfer of knowledge to the workplace. It is a cost-effective training. However, there is a possibility of interprofessional friction. So what lesson we learned from whole of this training is that only training is not sufficient. We need to have a complete system of monitoring of infection and feedback to the healthcare professionals. Otherwise, the effect of this training will fade away with time. And the identified challenges of interprofessional training must be addressed by the facilitators before the frictions begin there. And it is very important to engage leaders in the master training plan because they are the people who can slow down the rapid turnover of the healthcare professionals. They are the people who can maintain the supply chain of the supplies of the things which are essential to implement these guidelines. And moreover, the leaders are the people who can give opportunities to their co-workers so that they can go and have this type of the training. So thank you very much. And from this picture, I just want to tell you that this is one of the leading professors in neurosurgery. It was very hard to get time from him to have interviews. For the last 2-3 months, I was after him to give some time to me to have his interview. Then he says, okay, on Friday I take a break, come and have a lunch at my home, and I will give you an interview. So thank you very much. If there is any questions, please.
Thank you very much for a clear presentation of your summary of your thesis. The opposition will be opened by the chair of the Thesis Assessment Committee, Professor Frank Smeek. He is Professor of Quality Improvement of Residency Training at Maastricht University and at Catharina Ziekenhuis in Eindhoven. Professor Smeek.
Thank you, Mr. Prorector, and thank you, candidate, for your nice presentation on your studies. First of all, I would like to compliment you on your marvelous work and the completion of your PhD thesis devoted on the prevention of surgical site infections in low-income countries. And of course, I would also like to include your PhD supervisory team into my compliments. Your work resulted in 4 original articles, all of these already published in well-respected peer-reviewed scientific journals, and more importantly, in a training program for professionals to increase awareness, knowledge, and behavior of these professionals to reduce surgical site infections. In doing so, you also showed that you were able to explore your various research questions by making use of different kinds of study designs, which makes you a real scientist in my view. And if I'm not mistaken, you combine this research with your job as an anesthesiologist, which makes this even more admirable. Although I'm a pulmonologist and surgical site infections are not a major issue in my profession, I've nevertheless read your thesis with great interest because it's well written and each chapter follows the other in a logical order. But as you will realize, it's not only my job to give you compliments, but also to review your work critically and have an academic debate on some issues that crossed my mind when reading your thesis. And in doing so, I would like you to go with me to chapter 2, in which you stated in the introduction paragraph on page 21, however, especially in low-income countries face challenges regarding the use of evidence-based guidelines. You didn't give a reference to this statement, and I wondered, is this problem of adhering to evidence-based guidelines more a problem in low-income countries than in high-income countries? Because in the first paragraph of this introductions, you give some examples in the UK and the USA of problems of adhering in these countries to the guidelines. And several years ago in my own hospitals, we had a big problem of adherence to just simple hygiene guidelines by the professionals. So do you really think that adherence to these guidelines is a special problem in low-income countries compared to high-income countries, or am I mistaken?
Thank you very much, highly esteemed professor, opponent committee member. It's a very interesting question. I do not have too much experience of working in high-income countries. About 6 months I worked in UK and also one of the university hospitals in Pakistan. That is one of the leading university, the Kahn University Hospital. And I did my training there. If I compare to that experience and go to the other low-income countries, or especially the public sector hospitals, people don't even have an idea of the guidelines. Everyone have their own rules, everyone have their own thinking, and they follow that. And they say that we are doing this for last 30 years, we are doing this for 40 years. Yes, I agree with you that even in the high-income countries, people do not follow the guidelines, but the condition is much more worse. Even if you see in the start of this, my presentation, I says that 1 in 10 people in low-middle income countries get surgical site infection. The condition is much more in Africa, where 1 in 5 women get surgical site infection. But if we compare this result with over in Europe and or in United States of America, so it is very clear that although maybe there is a problem in high-income countries, but the condition is much more worse.
I wondered, wouldn't it be more a problem of intrinsic motivation, whether or not there is adherence?
Yes, you can say, but maybe there are different barriers in high-income countries. The barriers are of different type. Like in my case, there's no education and training available to healthcare professionals. Maybe education and trainings are available to healthcare professionals in high-income countries. That I'm not sure, but I think they are available to them. But there is no training and education available to healthcare professionals in low-middle income countries. And it means that there is lack of awareness, familiarity, they are not familiar with the guidelines, And especially when the new guidelines come, they do not familiar with. Pakistan published their guidelines to prevent surgical site infection in 2016. And I asked different people, none of them were aware about that guidelines. Even myself, I was not aware of those guidelines. When I started doing my thesis, then I come to know, yes, Pakistan also have their guidelines.
Okay, you stated that there are no training programs on this in low-income countries. But if I look at table 2.1 on chapter 25, of course, knowledge, education, and culture scores the lowest, but still the scores are above 2.5, and 2.5 being the middle of between 0 and 5, the highest and the lowest scores that can be reached. So one might expect this is sufficient?
If I say, see, I measured, collected data from two different hospitals, one in the private sector and the other in the public sector. It's, you can say it's maybe my weakness that I did not separately compare the data from those two hospitals. The private hospital is JCI accredited hospitals. Still, there are some guidelines. There is more awareness in that hospital because to get JCI accreditations, they have to work more. The condition is much more worse in public sector. That's the reason this data get diluted. I think if we go only to the public sector hospitals, we will find the conditions are much more worse.
Okay, that's an impression you have. Then I would like to zoom in a little bit more on this table in Appendix 2A. Item number 14 states, I do not have to comply with SSI guidelines. Well, I wonder if you work in a hospital and you work in an operating room, I would say that everyone would agree or strongly agree with this statement. And yet the mean score is 2.0, which means they somewhat disagree with this statement. Am I correct?
Yeah, you are correct. Because actually they're not aware of, they do not have awareness of the guidelines. And even the institutional do not want or do not force them or do not ask them to follow the guidelines.
Okay.
Okay. So that's the reason I feel that the score is less.
Because another question I have with regard to this item is, it seems to me that the higher score on item number 4 would be a more favorable outcome compared to a lower score. Item 14, the lower the score, the more favorable the score is. Do you agree? If you disagree with the statement.
Can you say the statement again, please? Because I'm not able to.
I do not have to comply with SSI guidelines. So if you score 0 or 1, that's admirable, because you disagree with the statement, I do not have to comply.
Sorry, I didn't.
You may give a short answer.
Maybe they feel that
we'll discuss it afterwards, because I think you should have posed the question in a positive way, and then you get a positive answer, so a higher score, and then it adds up to the positive score on item number 4.
Okay, thank you.
But we can discuss it later. I'm satisfied with your questions, and I give the word back to the pro-rector.
Thank you very much.
Thank you, Professor Mink. The opposition will be continued by Professor Jacqueline de Graaf. She is not present here in the aula, but she is present online. And she is Professor of Professional Development in Medical Education at Radboud University in Nijmegen. Professor de Graaf.
Thank you, Pro-Rector. Dear candidates, I would also like to start with a compliment. And I would like to compliment you and also your team of supervisors for embracing this very challenging PhD research project. And I have deep respect for your passion and also your commitment, as I read, to this very complex and very important topic in a very complicated context in 2 institutes in Pakistan. Now you have accomplished a major job to improve the implementation of surgical site infections in the ORs by designing and evaluating both training for healthcare workers and also developing a master training plan, at least an outline of it. So this compliment comes with a question, as you expect from me as part of the committee. So my first question will get into chapter 4 and chapter 5, because if I read those two chapters, I wonder if you agree with me, but in chapter 4, I read that you have 145 participants who followed the training program. And they valued the training highly, and they were eager to participate, and they showed increase in knowledge. And you also wrote that they were very enthusiastic about the format, especially also not only the authentic tasks, but also the interprofessional approach and reflective sessions, where they considered that promoted the transfer of learning. Do you agree with me that that's one of the conclusions that you have from chapter 4?
Sorry, please, can you repeat your question again? I just said that...
It's not a question, do you agree?
Yes, I agree that the participants, they were happy with the interprofessional training. Yeah, I agree with you.
Oh, that's very nice. I compliment. But now in chapter 5, you designed a master plan. And the outline of this master plan was evaluated by interviews with stakeholders like policymakers, teachers, and also managers and other leaders. Now, when you take a look at page 79 in table 5.4, there you describe 4 themes that come from those interview data. And there, to my surprise, you say that those stakeholders say that interprofessional collaboration and putting all the different professions in a training comes with challenges. That's also something you mentioned in your introduction talk. Now that feels a little bit like all the participants that you interviewed and in whom you evaluated your beautiful training program, they did not indicate it as a problem. So who do you believe more? The policymakers and the leaders who judge by reading an outline, or the participants who were really in the course that you made? So how are you going to deal with these two contradictions?
Thank you very much, highly esteemed opponent committee member. A very interesting question. If you see that different type of the participants, I use from in case 4, they're mostly healthcare professionals working in the operating rooms, or I can say that the real workers there. And in next chapter, I used policymakers and teachers, and they raised a red flag, although. But if we go back into chapter 3, where I try to evaluate my design, and people were more happy with interprofessional training. And I will go with the participants in chapter 3 and 4, because they were the people who really get the training. Those policymakers, medical teachers or managers, they do not have this training. So we just gave them an outline of the master training plan. Yes, they raised the red flag, but we should be very careful that such things should not happen in our training. Otherwise, the effect of the training will fade away, or it will not be a good training. So that's the reason we say that facilitators should be well aware that this thing can happen. But in our experience, we do not face this problem. That's the reason I think that I will go with the healthcare workers in the chapter 4, because they are the people who really get the training. The people in participants in chapter 5, they do not have that training. Maybe if they have this training, they will not raise this red flag.
Maybe you should let them follow the training and see what happens, see what kind of impression they get. So I'm happy with your answer, because I think you should go with the participants. But then in the summarize you make of your thesis, you say that you have 3 major insights. And in those insights, you also refer again to the challenges of interprofessional training. They must be addressed. So you're now a PhD, and I hope soon to become a professor. Your influence circle has widened. How are you going to address this?
First of all, I feel that there should be experienced facilitators who have a good experience of running interprofessional training. And the facilitators should be from all the professions. I mean, there should be a facilitator from the doctors, from the nurses, and the technologists. And when any friction comes in a group, I think it's better that the facilitator intervene as early as possible. And he should go and ask them that what is the problem they are saying. And once he knows the problem, then he asks them, what is your goal? So goal of whole the group is to prevent surgical site infection. Then he should go and ask the same group that this problem arises, how you people will solve this. Once ask them to brainstorm and solve this issue. And once they solve that issue, then you, in a democratic way, you can ask them that what is your people opinion, and then you develop a consensus among the group and then give the real answer or the real solution to the group.
And do you have any ideas on how you can try to implement this in the real practical world? So the work floor where they are really doing their jobs, because doing it in a training is differently from doing it at the workplace. And actually in chapter 3, all the participants also indicated that you should go to workplace-based assessments and feedback. You did not introduce that into chapter 4 in your improved design, but do you have any ideas of how to implement that?
Again, you may give a short answer. We have to move on. You may give a short answer, please.
Okay. See, like there was a shortage of supply. Some of the surgeons don't like to use clippers. They are very costly in the low-income countries. So it's difficult to convince them if they do not have a training. If they get the training, they also come on the side of the healthcare professionals who have this training. And once you convince the at the level of the policy makers, managers, then no razors will be available. And when the no razors will be available, of course, even the senior people have to follow the others. So frictions come.
We have to move on. We have to move on. Eh? I interrupt you.
No.
We have to move on to the next opponent. Thank you, Professor de Graaf. The next opponent is Professor Scherrebier. Professor Scherrebier is Professor of Quality Promotion of Medical Education, and he is the former dean of our faculty. Professor Scherrebier.
Thank you, Pro-Rector. Dear candidate, I really enjoyed reading your thesis about such an important topic. First of all, my compliments for you and for your team. Very good studies, 4 papers, fantastic. Very nice that the research methodologies you have used are so far away from your original studies in medicine. It must be not easy for you to learn and practice this approach. It's wonderful that you closed the circle in your thesis. You found out what factors are hindering, designed the program, and invested how it works. Fantastic. I want to learn from all your experience. Can you explain me in which other countries your training could be applied and what are the potential issues in implementing the training?
See, if you see on the training is based on current instruction design principles. I think that this training is specially designed for low middle income countries, but we cannot stick to low middle income countries. This training can go to any context, even in the high income countries. But maybe the barriers in those countries will be different. So first of all, we should have an insight into the barriers which are hindering these factors in that context. Once we know those barriers, then we can come to the current instruction design principles. You can use these same current instruction design principles, but the tasks may be different because these tasks you have to design according to that context, according to the barriers which are highlighted, or the insight you will get by studying the barriers in those contexts. So I feel that this training can be implemented in any context, but especially we designed it for low middle income country.
Okay, a new PhD in a high income country, I see coming. Then I would like to ask the panel to read out Proposition 6 loud, please, for the microphone.
Engaging leaders from healthcare institutes are vital for infection prevention and control.
Thank you. Then I would like to ask you to explain me why you need leaders for that, because I'm not so impressed by leaders and their effectiveness.
Yes, very interesting question. Actually, we have to involve them. See, like in our context, there is rapid turnover of the healthcare professionals. Mm-hmm. Although I know that these are the university hospitals, they're just like schools. Mm-hmm. Every year, new residents come, new medical students come, new nursing students come, some graduates, and there is continuous new people are coming in those countries. Mm-hmm. Then we have to spare these people on the job. Otherwise, they will not go for the training. So if we do not involve these leaders, then it's difficult for the healthcare professionals to have these trainings, mm-hmm. because this training is during the work, during their job. So if we do not involve them, mm-hmm. then it becomes difficult to have these training. Then supplies is also an issue. If we do not engage leadership, then maybe the supply chain is not maintained. If we convince the leaders, then maybe we will be able to maintain the supply chain.
Okay, I understand. Still, I think that you need more the consultants at that level to be convinced of these things, because often, I don't know how it is in Pakistan, leaders are a little bit far away to have such an impact. But thank you, I'm convinced with your answers, and because of time, I give the word back to the rector.
You may if you have a short question, that's allowed. We have time for a short question.
That's okay.
Okay. Thank you, Professor Scherbier. The next opponent is Dr. Mohammed Al-Iraqi. He is Associate Professor of Medical Education at Gulf Medical University. Dr. Iraqi.
Thank you, Mr. Rector. Dear candidates, I concur with other opponents on your commitment to this project and get your high-quality studies published in a peer-reviewed journals. Also, I would like to commend your supervisors for guiding you to have aligned these studies to explore the serious issue of surgical site infection. Excellent. My first question, it's about the contextual variables of interprofessional education. What are the limitations and the cultural underpinning that you experience while implementing these programs, while you're having people from different seniority levels, different professions? And I'm aware about the Asian and Arabian culture where there is a high power distance. So can you share your experience about how did you manage to establish an interprofessional program in your context?
Thank you very much, esteemed opponent committee member. Yes, it is a challenge, especially in the Asian context, because hierarchy matters too much there. And especially senior people, they do not like to have a training with the junior people. So still you can have interprofessional training, because in that group, you can include senior surgeons, senior anesthetists, senior nurses, or senior technicians. But if you see in our second study, one participant said that they were happy to learn from the seniors. So seniors are also gold. They can teach them many different things. They can discuss their experience with them. So I don't feel that there is too much problem in having interprofessional training. Even there is difference in hierarchy, especially in the Asian context.
Your microphone. Can you hear me? Your microphone was closed, so please open your microphone.
So I think that you mean to empower seniors to act like mentors during training, which makes the training effective. Is that what you mean?
Yes, to some extent, yes. But I'm telling you that you make a group of senior peoples. This is another way out to do the same thing. But in our real experience, we do not face that problem. Even people were happy to learn from the senior people. They want to enjoy their experience.
Great. I'm satisfied with your answer. Thank you. I have another more question that it's about after this PhD program or this after your project, do you have burning questions to be answered in future postdoc studies? Because you've mentioned something about the frequency of training or refresher courses, training, retraining, training, retraining. So how do you think to proceed further within the same line of scholarship that you have?
We did many trainings, retrainings, but we did not measure that what effect of this whole project is on the surgical site infection. So I think it's better that we do a clinical audit before doing this training, and then we do another audit and see what the difference this studies or this training make it. And for that, maybe it will take a longer time. So still, I don't know that what impact this training will going to make in the future. So for that reason, I think we should know that is this training is able to reduce the surgical site infection or not, or is this training increase the compliance with the guidelines or not? So those questions still remain to be answered.
Thank you very much. I'm satisfied with the answers of the candidate, and I give the floor back to the prorector. Thank you.
You may have time for another question if you like.
Okay, there is a question about the late comment that you mentioned something about measuring the effectiveness. Do you think of other KPIs related to surgical site infection training other than clinical audit that you mentioned? Other key performance indicators.
Sorry, please can you repeat the question?
Do you think of other ways to measure effectiveness of your training or other key performance indicators, like clinical audits? What else that you can measure?
In clinical orders, you can see that the incidence is increasing or decreasing after training, or you can have a silent observers in the operating rooms who just see that the training had increased the compliance or not with the guidelines.
Excellent. Thank you very much. I'm satisfied with the answer and give the floor back to the prorector.
Thank you, Dr. Al-Iraqi. The next opponent is Professor Laurens Stasse. He is Professor of Gastrointestinal Surgery, especially training and education at Maastricht University and Maastricht University Medical Center Plus. Professor Stasse.
Thank you, Mr. Prorector. It's an honor for me to be able to discuss with you, to ask some questions in a minute, but also, of course, to give you a compliment on indeed what Professor Scherpie said. You closed the circle. You did very nice research, very important research to implement knowledge and behavior on preventing surgical site infections. And compliments to your team, of course. But also compliments because you have been working abroad, you have a professional there, and it's really difficult when you have such a profession to do a PhD thesis as well. Our young residents that are even, I'm sorry, younger than you, they often have a lot of problems doing this together, working and doing research, but you did. Thank you for that.
Thank you.
I'm a surgeon. I've just been introduced as a surgeon. I'm even a gastrointestinal surgeon. And that brings me to my first question. I was a bit surprised, but pleasantly surprised, that an anesthetist took the lead in this project to reduce a surgical complication. At least that's the old-fashioned way I look at it. I think a surgical site infection is especially a surgical complication. Or isn't it?
I 100% agree with you that it is a surgical site related to surgeons. you can say, even I can say that even this is their problem. But in healthcare professionals, no, we work as a team. If we win, then the whole team win. If we lose, then the whole team lose. It does not mean who scored the goal. So another, if you see most of the intervention, most of the things, it's in the hand of the anesthetist. For example, prophylactic antibiotic, give within 1 hour before incision. Who give antibiotics? It's the anesthetist who can give that antibiotic. Maintain normothermia during the surgery. Who is responsible for maintaining the normothermia during the surgery? Anesthetist. Maintain normoglycemia during the surgery. Who is responsible to do that? Anesthetist. Only one thing is left, use of clipper. So as a team member, he can have an eye on use of clipper or eraser.
That's a very interesting approach, and I like it a lot. Let me take you back, 30 years. I did some research by then. I defended a thesis, and surgical site infections were involved then as well. I'll mention a couple of things. First, about the figures, the numbers you use. You say that in low and middle income countries, you show the numbers, which you didn't show, I think, or I couldn't find them in your thesis, but you mentioned them. It's up to 30%, 30% of surgical site infections. And then in the Western world, you say that it's up to 5% max at this moment. In the 1990s, the figures in the Western countries were between 5 and 40%. These were the figures given by the National Research Council. And the one most important cause was bacterial contamination. And all the other things were not mentioned. Then the surgeon thought he was the problem. This thing of bacterial contamination, is that still a problem, or are all the other measures much more important?
Still, the bacterial contamination is a problem. Of course, if you see that sterilization techniques had improved many things in the surgery, or we can say the sterilization technique had bring a revolution in a surgery. If those sterilization techniques are not there, then the bacterial contamination is much more problem. Yes, it is a problem there, but along with it, we have to follow the guidelines.
Yeah, and at that time, everybody thought it was the problem of the surgeon, and convincing the anesthetist to take part in the process of preventing surgical site infection was really difficult. You say that you are a low and middle income country, which gives us a bit of the opinion that you lag behind, you are behind us, but probably in your country, the anesthetists are very much aware of their role, and they take their role. Is that only you or your hospital, or do really anesthetists in Pakistan take this role so prominently, as you say?
See, still I believe that surgeon is the captain of the ship. We are a member of his team. So as an institution, I think if the institution divide the responsibilities, then it must become much more easier. That everyone play his roles and responsibilities, then it become easier. If we start blaming each other, then I think at the end we all fail. So it's better that we divide our responsibilities, and those responsibilities which were divided or dedicated to that person, they should follow their responsibility.
Okay, then I want to make you a big compliment. You may be still behind in the figures, the numbers, the incidence of surgical site infection, but the teamwork, you are really where you should be, and you are as far as we are. So a big compliment for that. I do have time for another question, and that's about, that was a bit about culture and teamwork and interprofessional working. Another thing is also about culture. You mentioned that surveillance is important, is one of the measures to improve surgical site infection. Surveillance can take place at an institutional level or at a national level. But that's really difficult. Do you think your country is already ready for implementing a surveillance program?
I don't think so, because still the institutions do not have a surveillance. First, we have to develop the surveillance of infection at the level of the institution. then that data can go to the local or regional or to the national level. So first we have to develop surveillance at the level of the hospital. Especially, we can choose some special type of the surgeries like cardiac surgeries, open heart surgeries, total knee replacement, total hip replacement, those which are considered much more cleaner surgeries compared to the other one. And we see that what is the incidence in those surgeries.
Yes, and will you have these figures, indeed these numbers? Because when we started that 20 years ago in the Netherlands, or maybe even longer, it was difficult to get the real numbers. Because transparency is dangerous. Other people are looking into your numbers. Is that no problem in your country? You
No,
say we can get the figures from cardiothoracic surgery. Are people open and transparent about it?
I 100% agree. It's a big problem. But if somebody who is neutral and we can keep the numbers within the hospital or within the institution, or instead of blaming others, I think that is still possible.
So you do not fear that in your country at this moment, at an institutional or even at a national level, you are still in that blaming atmosphere? That's...
Yes, still it is there. But once we have a concept of the team members, then I think we'll be able to reduce that. Still, the blaming culture is there.
Okay. Well, I hope that you will be very much involved. Well, I don't doubt that you will be involved. And the positive attitude you have is very important to make such programs a success. And of course, there's a little thing about cost. And we were talking about low and middle income countries. The whole building of a surveillance program often takes a lot of money and a lot of people that have to be paid as well. So good luck with that. I think I'll hand over the word to the pro-rector, and if there's time for another question later on, I'll be there.
Thank you very much, Professor Stassen. The opposition will be continued by Dr. Juliette Beuken. She is postdoctoral researcher and teacher at Maastricht University and at the School of Health Professions Education. Dr. Beuken.
Thank you, Mr. Pro-Rector. Dear candidate, first of all, I also offer my congratulations to you and your supervisors. With your thesis, you have stressed the need to invest in the prevention of surgical site infections in your home country and have thereby contributed to global health equality. And spreading the unpopular message that things need to change is never easy. So I applaud you on each step that you have taken for this important mission. And today marks another important step, and I hope you will enjoy the final minutes of it. I am sure you have prepared for this day in different ways, and my first question is actually about that. May I ask, in what ways have you prepared for standing here and defending your thesis?
All the thesis I did myself.
Mm-hmm. And have you taken any steps to, for example, prepare for answering the questions that you received today? Have you prepared your presentation?
Yes, I did presentation with my supervisors. Then every day almost, second or third day, I do present all this to my wife. She is the only audience. She is sitting there. She is correcting me that this is problem you are facing. So, or sometime when we do not have a busy list, I go to the recovery room and ask the recovery room nurses, please sit for me. I want to give this presentation to you.
Okay, so you've done the work for that. And what I think I hear you saying is that you practiced for things going right and not for things going wrong here, right? Is that true?
Sorry, please, can you say again?
So did you practice doing the presentation and the answering wrong, or did you practice doing it right, correctly? I'm catching you a little bit off guard here, right?
It's difficult to say. I tried my best.
I think you did, because you're doing a good job right now, so that is why I think you practiced doing it right. What I'm actually pointing towards is that I think in literature about patient safety. We often come across pleas for a shift from patient safety 1 to safety 2. And in short, safety 1 approach focuses on preventing mistakes by analyzing what went wrong. And safety 2 focuses on stimulating good practice by analyzing what goes right. And in patient safety education, I think we often fall back on the things that go wrong, presuming that people learn from mistakes the most. So I was glad to see that you take a different approach and you choose to use a video about good practice in one of your educational interventions. And I'm wondering why you make this decision. What makes you go against the tendency to focus on mistakes and actually focus on good practice?
Why a good practice? See, I want to, good practice, I want to show people from their own people that they are implementing the, if I take a video from a high income country, people may say that yes, this has happened in United States of America, maybe it happens in Netherlands, but we cannot practice this. So that's the reason I made a video working in the real context from the people implementing the surgical site infection guidelines, so that it's easy for the people to convince. And once they see their own people, that they're implementing the surgical site infection guideline, they say that, okay, if they can do it, why we cannot do it? Okay. So I think that's the reason behind it, that we took example from our own context.
Mm-hmm. What would you think would have happened if you used a negative example? So using an example of something that goes wrong.
See, even we use that negative, it is also a motivational factor. But then we have to tell people in the end that that example was a negative. In case of role plays, there were few examples of the negative, like someone comes and he explained that he had this surgery, and he get a surgical site infection. Then he said maybe they forget to give me antibiotic, maybe they used razor instead of clippers. So those role plays was used. But in the end, we correct them that this is the problem, and because of this problem, this thing can happen. So we have to be very careful. And then I asked them to compare these examples with the good practice. And also we ask them that what you are practicing nowadays, please compare it with the good practice shown in the video. So we had a discussion during the groups when they are solving the task. So then they learn the good practice.
Thank you. I like that answer, and I like the approach you've taken. Another part of the approach that I very much like is the interprofessional one that you chose. And I was not surprised to see that healthcare professionals generally appreciate the interprofessional character of your education and become aware of different contributions they have in prevention. But you also mentioned, and Professor de Graaf already mentioned this as well, that interprofessional education leads to friction and conflict. And I think I even heard you say that with these conflicts, the effect of the training would fade away. And this is something that I somewhat disagree with, because I think that conflict can actually be a very teachable moment if you use it right. And I'm wondering what your interpretation of conflict is, and if you could agree with me that in some ways conflict might actually be a learning opportunity.
I 100% agree with you. Sometimes conflicts, it is very good. Then you can go in a deeper form of the discussions. But instead of, why I say that it's not good when you start blaming each other. If we have a positive mind and we start learning from our conflicts, and we learn from what goes wrong, what goes good, then it is helpful. But if we use the conflict only to blame others, then it is not good.
Okay, thank you. I have one final question, and this is perhaps one that I'm asking mostly for myself, because I've seen you had a very high response rate in some of your studies, up to 90%. And I would like to know how you did that.
Because actually, if you see in the operating rooms, most of the people, they work in teams. Mm-hmm. And then I assigned someone from each team. Like if there is an operating room number 1, so I ask someone from there, please collect data from all the healthcare workers working in your operating rooms. So these people, they helped me in collecting more and more data. So if somebody had not given me the form back, so they go and request them again and again, please fill that data. That is very important. It's very important. We have to design a training for them. So we try to convince them again and again.
Mr. Kahn, you will have noticed that the time for defending your thesis has passed. The committee will now withdraw to discuss the quality of your thesis, and in particular the quality of your defense. And I would like to request you, please await here until we return with the results.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. All your time, 'cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. Even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. Southside, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
It's a nice.
You put a lot of work in it, so.
All right, please.
Mr. Mohammed Kahn. The degree committee here present, not only here but also online, has assessed the quality of your thesis and the quality of your defense. And in view of this positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. And Professor Van Mook is authorized to confer upon you this academic distinction in accordance with Dutch University custom and law, and invite now your supervisor to take the floor. Professor Van Mook.
Thank you, Pro-Rector. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Mohammed Nasir Ayub Khan, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Dr. Verstegen, the floor is yours.
Dear Dr. Kahn, we are so proud of you. And this is a moment that we tend to look back, and I remember our start in 2015. I actually saw a first email that said, please, I need your feedback. A very typical phrase I remember. But when you were here, I think we were immediately impressed with your ideas and your enthusiasm. But I remember also being a bit doubtful, and I remember talking to you and trying to explain that it was really a lot of work, and were you really sure that you had enough time? And you looked at me kind of amazed and said, of course. And your enthusiasm at that moment convinced us, and we started on this journey with a little doubt in our minds maybe, because I wasn't sure you had enough time with work and family life and everything that you were doing. But your enthusiasm stuck. Even after we sent you a lot of feedback, and a lot of feedback, and a lot of feedback, and a lot of feedback. But you enthusiastically send us a new version, and a new version, and a new version, even within a couple of hours sometimes, right? So we worked hard, you worked hardest of all of us. Sometimes it wasn't immediately clear whether we understood each other. Especially, I think, when the two ladies in your team started to talk about educational theories and principles and different methods of research. We struggled a bit in understanding, but then we had wonderful online meetings. And I have the best memories of our one-to-one meetings, where I felt we had real discussions and the kind of critical reflections that you've shown today to the committee as well. So we got there. And we got there because of your enthusiasm, the main theme that I remember from the past years. Your continued efforts and your hard work, but mainly your enthusiasm to go on and work on and do even more. Usually PhD students have this lapse of motivation when there's a point that they are not really sure it's worth the effort. You never ever doubted for a moment that you wanted to continue, and you remained enthusiastic, maybe because you had your goal in mind. And that's, I think, what we've seen today as well. You've talked with so much fervor of the importance of your mission and what you have achieved and what you will achieve more in future. And I think Dr. Al-Iraqi told us and explained to us back there when you couldn't hear us. He said, I see a new leader of medical education in Pakistan, and I see that too. And I congratulate you. I congratulate your Vice Chancellor, Dr. Mohammed Iqbal Kahn, who couldn't unfortunately make it today. I congratulate all your colleagues, but also your wife and your family and yourself.
Esteemed Dr. Kahn, dear Mohammed, it's my great pleasure to congratulate you with your doctorate, and I congratulate you also on behalf of the Board of Deans of Maastricht University. And I would like to share some impressions of the committee with you. We have seen that you did study important and relevant topic, but also a difficult topic. And what we appreciated is your design of your studies and also the excellent line that you showed in your studies. And you also used a good methodology to study it. So we appreciate that. And also we have appreciated your defense. Well thought about it, well answered, and not always easy questions. They were quite challenging. And you showed that you are critical, but also self-confident, and knowledgeable in the field that you studied. And we appreciate very much that you emphasized the teamwork, the importance of the teamwork in your studies, and you showed that very, very clearly. So I would like to congratulate you, not only you with that, but also your 3 supervisors. Professor Van Mook, Professor Dolmans, and Dr. Verstegen. Congratulations with the result that we have seen today in the form of a good thesis, good publications, and well, you had quite some years, I think, of guidance of, like usual, with candidates that study for a long time, and of course that need guidance, but you see here the good results of your hard work and your investments of the last couple of years. Of course, I would like to include in my congratulations also your family, your spouse, your children, your mother, and all the colleagues and all those who have contributed to the results of your studies and the results finally in your thesis. So your family, friends and colleagues, all of you, congratulations with the result that we have seen today. I would like to thank all the members of both committees, both the Thesis Assessment Committee and this Degree Committee. Thank you for your input, and in particular the external opponents and all people that have contributed to critically reading the manuscript. And I would like to thank you for your interesting questions today. So thank you in particular, external members of both committees. Maastricht University appreciates your input. Well, then we come to an end of this academic ceremony, but before we end, I would like to invite the two online opponents to congratulate the young doctor. And I would like to start with Professor de Graaf.
Thank you very much for this opportunity. My congratulations, Dr. Kahn, and my deep respect for your accomplishments. And I wish you and your family and your kids a bright and healthy future privately and also at your work. And please, please, please keep up the great work you're doing right now. Pakistan needs you with your bright team spirit, and you are a new leader now. And please allow me, Dr. Kahn, to share with you a famous quote from Sigmund Freud. Why? Because you and I are both cat lovers. Time spent with cats is never wasted. I wish you all the luck.
Thank you very much. May I invite Dr. Al-Iraqi, Mohammed.
Dear Dr. Kahn, congratulations. I enjoyed reading your thesis, and I know the great effort you have put into this project with the support of your excellent supervisors. You have done a great job. Good luck with your scholarly endeavors. Wish you all the best. Mohammed Al-Iraqi.
Thank you very much for your congratulations. Well, I have one announcement to make. I would like to invite the committee to take a picture with you in the middle and the two online opponents still on the screen, and then we will make another picture in the hall of this building at the stairs, and thereafter we will have a reception in the rafter. And then please follow us, you will get there. Hereby I close this academic ceremony.
All right, now